Exercise Theory, Chapter 3, Anatomy. This is the first of 2 videos of anatomy. What is anatomy? Anatomy is the science of the structure and the function of the body. This chapter in the textbook is going to focus on the musculoskeletal system. That is our goal, and this is what we're going to use most as fitness leaders. So we're really going to be concerned with the naming of the bones, the joints, the ligaments, and the muscles that work together to produce movement. This is not all there is to anatomy. There's many other subgroups that you could talk about, but we're going to be focusing on these because they will make the most difference for you and your career. The other thing I want to point out as we start anatomy, this is a very overwhelming chapter for people that are new to anatomy, that have perhaps not studied this in the past. I recommend you take things slowly. I recommend that you have your textbook handy and that you have the pictures open in front of you. We're going to be following in the same order that the textbook does. So when we're talking about the names of the bones, have that picture open so as I discuss them, you can see what they look like. And the reality with anatomy is it is a new language. So you are going to have to review and practice. So the first time through, it's a whole new language. It's going to seem very overwhelming. I expect you to go back, read the textbook, listen to the video again. And with repetition, everything will come easier to you. Usually, some of the feedback we get with most of the live courses is that it seemed that the anatomy section went too quickly, when in reality, the participants just need to have a chance to digest the information and to use it and to repeat it. Like learning a new language, the more you practice, the more you review, the different ways in which you review, the better you'll get at it. So we're going to start off our discussion talking about the skeletal system. So these are their bones and our joints. So we're going to be going through and listing all the major bones that you need to know and be aware of, and then we'll talk about the different types of joints. So important functions of our skeletal system, our bone system, is that our bones will actually protect our organs and our soft tissue. So when you think of the abdomen and the rib cage, etc., especially the rib cage and the skull as well, those are going to protect our internal organs. So our skull will protect our brain, our rib cage will protect our lungs and our heart, our pelvic bone will protect our reproductive organs. So there's actually a big role with protection. The next thing it'll do is it will actually give support to our soft tissue. If we did not have bones in our body, we would be a soft mass of mush. This is going to give us structure. Our bones will also produce our red blood cells. Our bones will serve as a reservoir for minerals. And then our bones actually will provide attachment for the skeletal muscles. So what we have is we have a muscle. It will go into a tendon, and that tendon in turn will attach to the bone. When the muscle contracts, the muscle will shorten and it will pull on the tendons, which pull on the bone. This is what allows for motion. This allows us for movement. So our bones don't move of themselves. Instead, it's the muscles that contract. And the final point that they make here is that our skulls are very, very heavy, and so through the way that our body is set up, we're going to distribute the weight of our skull, our head, throughout our entire body. So let's start with a little bit of naming. You're responsible for knowing these different bones. So the first one is the skull. The term we use is our cranium. Our cranium. Next is a clavicle. So if you feel like along your front and you go to your throat and go out to either side, our layman's term for this is our collarbone. You hear people talk about their collarbones. The real name is a clavicle. In the posterior part of the body, so the back of the body, you have your scapula. You might know this known as your shoulder blade. It's your scapula. Then we will have our spine, and the name for the bones of the spine are our vertebrae. It's pluralized here to vertebrae. Vertebra is one, vertebrae is multiple bones of the spine. Then if we go into our arm, our upper arm bone is called our humerus. Our upper arm bone is called our humerus. What confuses a lot of new students is our forearm, because our forearm will actually have two bones in it. So when you analyze the bones in the hand and the arm, you need to make sure you're positioning your arm with your palm facing forward. And the bone that's on the medial side or the inside is your ulna. The bone that is on the outside that leads towards your thumb, that is your radius. So again, the bone that is more medial, it's on the inside, it's closest to your body when your palms of your hands are facing forward. That is your ulna. Your radius is lateral, so it's more away from the body. That radius will go down and it is on the same side as your thumb. Where confusion will lie with this is that if you take your hand, and please actually do this, so sit there with your arm straight and your palm facing forward. If now you turn so your palm faces behind you, you'll see that your thumb is now on the inside and that your radius crossed over your ulna. So your radius will cross over your ulna. Once again, always analyze this as an anatomical position. And we'll speak of anatomical position in just a moment. Where the ulna is on the inside, your palm faces forward, and the radius that goes down on the same side as your thumb is on the outside. So returning to the midline of the body, that the vertebra will go down and they'll come to attach to your sacrum. Your sacrum. Your sacrum is going to attach to other bones, and these bones as a ring will make your pelvic girdle. Okay, so you'll have your pelvis or your pelvic girdle. Attaching to your pelvic girdle is your femur. That is your thigh bone, your femur. Your kneecap is called your patella. Your kneecap is your patella. Now, if we go into your leg, you will have your shin bone. So if you feel down below your knee, you'll feel that bone that's very prominent in the front. And you know you've hit this bone on a coffee table millions of times in your life. We all know what this bone feels like. That bone that you could feel there is called your tibia. What most of you probably didn't realize is that to the outside, to the lateral part of the body, we actually have a second bone there. You could feel it if you go up a little bit higher, right behind the knee. So go to behind the knee to the outside of the body, and you'll feel the top of your fibula. The way I remember those is that I know I have a tibia and a fibula, and I always think that we didn't, at least when I first learned it years ago, I didn't realize that we had a second bone there. So I always go, oh, you must be fibbing. There's not a second bone there. And fibula. That's just how I remember it. You could remember it anyway. So let's repeat these one more time. Cranium is your skull. Clavicle is in the front of the body. This is your collarbone. Your scapula, you have two scapula. They are behind you. They're your shoulder blades. Then you have your humerus, that is your arm bone. Then in your forearm, you're going to have two different bones. When you stand with your palms facing forward, the bone that is on the inside, on the medial side, is your ulna. The bone that is on the outside, on the lateral side, is your radius. And the radius will be on the same side always as your thumb. Your vertebrae are the bones in your spine, and they will go down and attach to your sacrum, which along with some other bones will create your pelvic girdle. You just need to know that that's your pelvis and your pelvic girdle. You're not responsible for the other names of the bones. Going into your leg, your thigh bone is your femur. Your kneecap is your patella. Your shin bone that you could prominently feel in the front in your lower leg is your tibia. And lateral to that, you have a fibula. The other one that I didn't mention, but hopefully you're all familiar with, is your ribs. You have ribs as well. So we like to classify things in anatomy, and one of the ways that we do classify things is into our axial and our appendicular skeleton. Axial and appendicular skeleton. The adult body does have 206 bones. Don't bother memorizing that. No one's going to quiz you on the number of bones that we have. But we do break into axial and appendicular, and you should be familiar with these. Your axial skeleton is what runs along your midline. It's made up of 80 bones. Don't worry about the numbers. But what this is going to be is it's going to be your midline axis. So it will be your cranium, okay, your ribs, your sternum, that's your breastbone. I'll point that out on the next slide. And your vertebra, as well as your sacrum. Everything along the midline. When you go beyond that straight midline, you're going to go into your appendicular skeleton. Your appendicular skeleton are your appendages, so your arms and your legs. And this is going to simply be everything else. So your arms, your legs, so that would be your humerus, your ulna, your radius, your femur, your tibia, and your fibula, as well as your hands, the bones in your hands, your fingers, your wrist. But then the ones that confuse people a little bit that you should know is that your clavicle, which is your collarbone, and your scapula, which is your shoulder blade, those are also your appendicular skeleton. And when it gets down below, your pelvis, so you'll think of your pelvis, is also considered to be part of your appendicular skeleton. So if you could remember your pelvis and everything beyond it in the lower extremity, and your clavicle and your scapula and everything else beyond that in your upper extremity. So here's just another drawing of it. So you have, once again, in greeny blue, your axial skeleton, which is your cranium, your vertebra, your sacrum, your ribs, and your sternum. Your sternum is your breastbone. You feel that in the front, okay? That's where the ribs come to attach in the front, your sternum. You're also responsible for that one. Your appendicular skeleton is everything else. So remember that clavicle and scapula are the beginnings of the appendicular skeleton in the upper extremity. So everything beyond that, the humerus, the ulna, the radius, etc., are all appendicular. In the lower skeleton, it's actually going to be your, just call it your pelvic girdle, okay, and beyond as well. So your femur, your tibia, your fibula. Okay, all of those will be appendicular skeleton. So we like to classify appendicular and axial skeleton. The next thing we like to classify bones by is their shape. Okay, so their shape and what they do. So the first one division we have are our long bones. Our long bones, the easiest example to think of are our arms and our legs. So in our upper extremity, that would be our humerus would be a long bone, our ulna would be a long bone, and our radius would be a long bone. Our fingers actually also will serve as long bones. In the lower extremity, our long bones are going to be our femur, our tibia, and our fibula. These bones mainly are going to work as levers. So muscles are going to pull on these bones, which are going to cause movement to occur. So the next category are short bones. Short bones are going to give strength to mobile joints. So keep this simple for yourself, but in our wrist, which we're not responsible for knowing the names of the different bones in our wrist, but in our wrist we have multiple bones, small little bones, and these would be considered short bones. If you took a look at the wrist bones, they seem to be as wide as they are tall. We have multiple ones there, as well as in our ankle. Okay, so below the tibia and fibula, our ankle joint there is actually comprised of several small bones. So we think of short bones there. Our flat bones have the purpose of serving as protection. So our flat bones would be our cranium, so our skull bones are a flat bone. Our ribs, even though they look long, if you actually see a rib, they are flattened, right? So they may be long and curved, but they're flattened, and they're there to serve protection to the chest cavity. Our pelvis as well will serve as a flat bone. The next category are our irregular bones. These are going to be oddly shaped bones, and the vertebra, so our bones in the spine, are the best example of an irregular bone. And we'll take them in a few slides. We will see a picture of a vertebra, and you will see clearly it is irregularly shaped. It's impossible to come up with any other term to describe its shape. That odd shape that they have is because of a bunch of different attachments that are on it that allow us to pull in multiple directions, and they're going to be very, very stable bones, which provide support for our body. And the last grouping are our sesamoid bones. Our sesamoid bones, they do grow after birth, okay, so they're still cartilage when we're born. And these are going to be bones that are embedded in a tendon. So I've already mentioned that we have our muscles turn into tendons which attach to bones. Our sesamoid bones will rest in that tendon. These are going to provide a mechanical advantage to the joint because it's going to play around with leverage. So the best example of a sesamoid bone is our patella, our kneecap, our patella. If you were to straighten your leg and feel for your kneecap, you'll probably notice that when the leg is straightened, you could push that kneecap back and forth. And the reason you can do that is that the patella rests in the quadriceps tendon. So the muscle on the front of our thigh becomes a tendon, which is our quadriceps tendon, and our patella will rest within that tendon. When our leg is straight, our knee is straight, our quadricep is relaxed, which allows more movement in its tendon. So really what this bone will do is it will pull the tendon of the quadricep further away from the knee, which makes it a more powerful joint. Okay, so sesamoid bones are bones that are embedded within a tendon. We also do have some in our hand and our thumb, as well as our great toe, but you won't need to know those. So be comfortable with the different types and be comfortable with the examples. So what an example of a long bone would be, what an example of the short bone. And with the short bones, you just need to know wrists and ankles. Here's a visual of all this. So you see the flat bone is, they use the frontal bone being on the front of the cranium. Okay, so that'd be a flat bone. A short bone, you'll be able to see there, you're just on an angle, so you're seeing about 4 of the different carpal bones, which are your wrist bones. Next, underneath that on the left-hand side is your sesamoid bone, which is your patella, and that's what your kneecap looks like. It looks like that, and it rests within the tendon of the quadriceps. Please don't worry about the suture bone. In our sutures, that's where our skull bones come together. Those are called sutures. Sometimes there's small bones that are embedded in there. You don't need to know that. And then here's a picture of a vertebra. As you can see, it's easiest just to call this an irregular bone. And then our long bones. So our femur, they're used as an example. There are long bones used for mechanical advantage. So let's start talking about some of these different bones. I want to mention the vertebra. These are the bones that make up your spinal column. They have the following function. They will support the body. So in that last picture, you'll recollect that there was sort of a round circle part. We were actually looking down on one of our vertebrae. And those will all stack together with intervertebral discs in between. And this is going to cause or enable us to support the body. Okay, all these will stack one on top of the other and allow to support the body. Because of these discs and these round-shaped bodies that our vertebra have, this allows us to bear the weight of our head, our neck, and our trunk. What the vertebra also do is they'll actually protect our spinal cord. So once again, if you look back to that picture that you have in your textbook of the vertebra where you're looking down on it, you'll see in the back, before you get all those odd projections of bone, that there is an empty circle, an empty ring in there. That's where our spinal cord will go through. So once again, in that vertebra, it's like you've cut the body in half and you're looking down at it. And that's where the spinal cord will go. Because the spinal cord goes through there, the vertebra serves to protect the spinal cord. The vertebra also provide a passageway for nerves. So when you look at the vertebra from the side, you'll see that nerves are able to come out at the different levels. And because of the shape of these joints, when they move, when muscles pull on these joints, it will allow us to flex, extend, and rotate the spine, as well as lateral bending of the spine. We'll talk about all these movements in just a moment. So here we have again the spine, the vertebra. And once again, on this one, if you're looking from the side, so that diagram you see, you'll see that they have those clear openings in between the front and the back of the vertebra. The spinal cord goes through there, and through those little holes that you see are where our spinal nerves actually come out. Please don't worry about memorizing numbers. No one's going to ask you how many bones will make up the vertebra and the spine, but understand the different sections of it. That is important. So our neck is our cervical spine. It's also said in England the cervical spine, so cervical or cervical. These are 7 vertebrae in the neck. In the diagram, these are yellow. Next, you'll have the thoracic spine. This is your upper and mid back. The thoracic spine are where the ribs attach to. So the level of your rib cage is your thoracic spine. The next is your lumbar spine. I always like to remember L for lumbar and low back. This is your low back, okay, your lumbar vertebra. And then your sacrum. Sacrum we saw in that last picture. This is a triangular shaped bone. It actually is 5 bones that fuse together as we get older. So our sacrum started out as multiple bones that fuse together. And our coccyx, that is our tailbone. So it's remnants of a tail that we no longer as humans have or perhaps never had. And so these are going to be very, very small little bones that will also fuse together. Just so you could understand different terminology you will come across, we tend to number these different vertebrae. So if you hear somebody talking about, oh, at C5, I have a disc herniation at C5, you would know that they were talking about the 5th cervical vertebra. So we'll talk about C and then a number, which is cervical. You talk about thoracic spine, so they might talk about an issue with T7, so you know it was a 7th thoracic vertebra. Our lumbar spine, same thing. We would talk about L1, L2, L3, L4, L5. It's just our shorthand. And then sacrum, we usually only refer to S1, but we do have all the sacrum, the 5 that fuse together. So let's start talking about joints. Joints are formed when 2 or more bones of the skeleton come together. So these are our joints. Almost all the movement in the skeletal system takes place at a joint. What is really happening there are you have 2 bones that come together and you have a muscle that will move those 2 bones. Okay? Structure of each joint is closely related to its function. So some areas only have a small degree of movement. So the example they give here, the vertebral column, our spine really doesn't have very much movement. When we move through our entire spine, yes, we could generate a lot of movement. But when we really think about one vertebra at a time, there's very limited movement. Other areas, usually in our appendages, so our limbs, will have a wide range of mobility. So once again, it's going to be structured and shaped for a wide range of mobility. We're going to classify our joints into 3 different types of joints. So first of all, though, certain joints are more mobile than others because of the type of joint that they are. So the shape of the joint, and you'll get to see in a moment an example of hinge joint and saddle joint. So how that joint is actually shaped can determine how mobile it is. The example I always think of is the elbow joint. You notice that you cannot straighten your elbow beyond a certain point. Well, the bones in the joint will actually limit that. The other things will be internal resistance of the joint. So sometimes the joint capsule itself limits movement. You could be limited by the bony structures which make up the joint. So that's a perfect example is that elbow joint again, that you cannot straighten it beyond a certain amount. As well as joint movement is going to be limited by the elasticity of your skin, your muscles, your tendons, your ligaments, and structures that will hold the joint together. So let's talk about the 3 different types of joints. I'm going to clarify one thing because probably a lot of you are going to find this initially a little confusing. When you think of joints, when you think about your hands and your elbows and your shoulders, you are going to be thinking of the 3rd type of joint which we will discuss, which are the synovial joints. Synovial joints are freely movable. So this first type of joint and a little bit of the second type of joint we'll discuss, you might not have considered as joints. Okay, so the first joint is a fibrous joint. Fibrous. There is no observable movement. It appears to not move at all. And this is because the bones over time have fused together. Okay, so the joint becomes bone. It does not move. So the example of a fibrous joint are the sutures in the skull. So what you're looking at in that picture is the skull. The head is it's pointed to the left, and you'll see the frontal bone and the parietal bones. They have all fused together. They were individual joints that had a little bit of movement. This is how babies get through the birth canals. Those joints are unfused at birth, which allow a little bit of movement. And then as we age, they fuse together. So that is actually a type of joint that occurs, a fibrous joint. The second type of joint are the cartilaginous joints. Cartilaginous joints. These are still only slightly movable bones. So the example for them are actually in your vertebra is the most common example. It's your intervertebral joints. So when you look at a spine from the side especially, or the front, you'll notice that you'll have these vertebral bodies, so this block of bone. And in between each block of bone, you have what's called an intervertebral disc. And what that actually is dense connective tissue in that space between the bones. Okay, so it's just kind of like a dense kind of padding in between the bones. It does not allow free movements, especially in comparison to the synovial joint that you will talk about next. Okay, so this will these cartilaginous joints, so these intervertebral discs, these are going to protect the two bones in the vertebra from wear and tear. It also will absorb shock, and it will allow some limited movement. So it will allow some flexion and extension and lateral bending of the spine. So cartilaginous joints are slightly movable. And they are going to be, the best example of them are the intervertebral joints. Also your pubic symphysis, so at the front where your pubic bones come together, so where the pelvis attaches at the front. This is also a cartilaginous joint. These, like I said, they don't allow very much movement. I often, in practice, will describe them almost like a jelly donut, kind of in between these different bones. With age, the cartilage, so this connective tissue is actually fibrocartilage. It will lose some of its resilience, and it causes the joint to be more susceptible to movement and injury. So usually as we age, you'll find that people's spines normally become less flexible, and that's because of some of the loss of the resilience of their fibrocartilage. So the third type of joints, these are the joints that you are probably in your mind picturing when you think of joints. These are synovial joints. Synovial joints are going to allow considerable movement. Okay, the only thing that really limits the movement of the synovial joint is going to be the shape of the joint and then the connective tissue around it. They're the most common joints in the body. They move because of the contractions of the skeletal muscles, And it's these ones that we study for understanding of exercise analysis. Okay, these are the joints that we're going to be picturing when we're talking about movement. Okay, so remember the first type of joint were the immovable ones. Okay, the fibrous joints, which were the sutures in the skull. The second one were cartilaginous, those are your intervertebral discs. And now we're talking about our freely movable joints, the synovial joints. So how does a synovial joint work? I'm going to describe all this. If you actually open up your textbook, you'll be able to see a picture of this immediately. I will talk through the next slide as well. But essentially, two bones will come together. When they come together, they are going to create a joint. That joint is going to be covered in connective tissue, which is going to create a joint cavity. So this joint cavity is a space, connective tissue will cover it, but it's going to be this space in between the two bones that allow for movement of the two bones. Our joint cavity will contain what's called synovial fluid. And synovial fluid is going to lubricate the hyaline cartilage at the end of the joint, of the bone, pardon me. So, think about eating chicken wings. Or let's think of a drumstick. Have you ever noticed when you eat a drumstick, when you get to the end of it, you'll see that kind of shiny stuff at the end of it. So it's not bone anymore, but it's a shiny, smooth material. That is your hyaline cartilage. That is hyaline cartilage that you're seeing. So when you have two bones come together to create a joint, a synovial joint, they're going to have bone, and then they're going to be capped in hyaline cartilage. And around the hyaline cartilage, it's going to be a joint cavity. So it's going to be all kind of enclosed in. What you no longer see when you're having chicken wings is the fact that there is synovial fluid in there. So that joint space is really microscopic pretty much in how much space is between these joints. But it's enough to have synovial fluid. Synovial fluid is amazing. It is extremely non-viscous. So picture it like oil. And so it's going to allow smooth movement of the hyaline cartilage against the hyaline cartilage of the other bone. We'll sometimes refer to hyaline cartilage as articular cartilage, which you'll see right away. So we have that joint cavity. The synovial membrane is going to surround the joint cavity within the joint cavity. This membrane is going to, the synovial membrane will respond to movement. So when you move that joint, it responds to movement by secreting synovial fluid. Okay, so when you move a joint, you will stimulate your synovial membrane to secrete within the joint synovial fluid. The synovial fluid will coat the ends of the articular cartilage or hyaline cartilage to make them very, very smooth to allow frictionless movement. So articular cartilage, same thing as hyaline cartilage. This is going to surround the ends of the bones and provide shock absorption. The other things you might actually see too, and it's not, a bursa is not specific, is not specifically usually within the joint itself, but we'll also see bursa. And actually all bursa are flat sacs of synovial fluid. And they usually be located between a ligament and a bone, or a tendon and a bone, and a muscle and a bone. Essentially, it's going to be just a soft, cushiony pad. So when something rubs against a bone, such as a tendon or a ligament or a muscle, that they don't get irritated. So that's all that bursa is going to do, is give cushioning. It's going to protect these two structures. So let's take a visual of what the synovial joint looks like. So here we have our knee joint. Okay, what they've done with this knee joint, they're actually looking, it's like they took a picture of the kneecap from the inside of the knees. So they're taking a picture, so because you can see the tibia, and I've already told you the tibia is more inside or medial. So I'm looking at the inside. At the top I see the femur, below I see the tibia, You can see the patella. You can see that patella. And like I told you, if you look at the top, there is your quadriceps muscle, and it becomes a tendon. So the muscle is the red part, the tendon's the white part. And if you can see that patella is laying within that quadriceps tendon. Once we reach the patella, after that we'll actually call it your patellar ligament, which will attach to the tibia. So you can see with this picture that quadriceps, if that muscle shortens, it is going to pull on the front of the tibia to straighten the leg. Now, within this joint, when you look at the femur, you see it come down, and it's sort of the skin color, the skin tone is the bone, and it comes down, and then it has that grayish blue cap. That is your articular cartilage. Remember my example of the chicken bone, that shiny pearl-like substance at the end? That's your articular cartilage. It comes to meet the articular cartilage of the tibia. So you can see the two of them meet. That dark blue space that you see there, okay, dark blue space in between, that would be your joint cavity. It is lined with a very fine red line of your synovial membrane. The synovial membrane will secrete synovial fluid into that dark blue space, which will lubricate the ends of the joint, allowing for movement. Okay? So let's look at those parts again. You have two bones, the femur and the tibia. They are both capped with articular cartilage, which is very smooth and shiny. They are going to come together. They will be enclosed. And in fact, you could see they're saying joint caps at the back. Well, that's going to work around in all directions. So it's going to cover that joint from all directions. On the inside of that dark blue space, you're going to be seeing a fine little red line. That is your synovial membrane, and it will secrete synovial fluid so that the two bones can move in a frictionless surface. You will also see in there a muscle on the top. The muscle is outside of the joint capsule that turns into a tendon. You will have in this example here a sesamoid bone, which is a bone located within a tendon, and that is our patella, which is our kneecap. And that after the patella, we'll have called the patellar ligament, which attaches that kneecap to our tibia, allowing us to straighten our leg when the quadriceps contracts. The other thing you will notice in this picture are those bright blue spots, the bursa. That's all you're looking at. That's just bursa. Those are those little sacs of synovial fluid, and you can see how they would help to protect against wear and tear from that muscle pulling against the bone. So now you understand what a synovial joint is. We have different names for the different types of them. So the components are the same. They have you have articular cartilage, you have synovial membranes, you have bursa sacs, you have joint capsules, everything stays the same, but now the shape of them can change. So we have different shapes. So I'm going to go through this list. You can be following along in the textbook. So as I go through this list, you can be looking at a picture immediately to see this. Otherwise, I will list them one by one. Okay. The easiest one, or one of the easiest ones in my opinion, is the pivot joint. So a pivot, the example is going to be the vertebra right at the very top of the neck. It's our C1 and C2. And what will happen is our first cervical vertebra is actually shaped differently. It's shaped like a ring, and it will pivot onto our C2. That is a pivot joint. The next is a hinge joint. Your easiest example and the easiest to remember this is your elbow joint. It allows one plane or one plane of motion. So you could flex and extend the elbow joint. Our knee is similar to a hinge joint. However, it's actually a modified hinge joint. So the best example for hinge joint is the elbow. A saddle joint is going to be a joint that allows movement in two different planes of motion. An example of that is going to be our thumb joint. Our plane joint are going to be is when two bones come together and they slide. So they don't hinge or rotate, but they glide one on top of each other. They don't glide a lot. There's not that much movement. Your example for gliding, our plane joints, are going to be the wrist joints or the ankle joints. These are usually plane joints. Okay. Our condyloid joint, this is going to be joints in our finger. This will actually allow movement upon two perpendicular planes of motion. And so if you take your finger, you notice how you could bend and straighten your finger and then you could take it wide and bring it together? Those are your two separate planes of motion that are happening at your condyloid joints. And your last one are ball and socket joints. So two examples here are your shoulder joints, your humerus attaching to your scapula, as well as your hip joint, your femur going to your pelvic girdle. It's like a ball in a socket. So it's freely movable. It's multiple planes of motion. Now, I understand that some of these types of synovial joints might be confusing. Please don't get too worried about them. Understand especially the pivot, hinge, and ball and socket joints. We'll see pictures of them in a second. Don't worry as much about the other ones. No, be comfortable with what an example of them are, which we'll talk about in one moment again. But please don't get too concerned. So here we're going to start on the left side of this picture, our pivot joint. Our pivot joint, that's a nice diagram that would be what was happening between C1 and C2. Our hinge joint is the next one, which is our elbow joint. Our next joint is going to be a saddle joint, and this is going to be between our carpal bone and our metacarpal bones, so where our thumb attaches to our wrist. Okay, that's a saddle joint. The other one you should be very familiar with is going to be our ball and socket joints, so like our hip joint. See how you can move in multiple directions. Our condyloid joints, these are going to allow movement in two different ones. They're actually using the difference between your radius, remember the radius bone that goes towards the thumb, and your carpal bones. Your carpal bones are your wrist bones. Okay. And then the last one is going to be a plane joint. They are mentioning here that it's between your tarsal bones. Those are your ankle joints. But you'll also find them between your carpal bones, which is your wrist joint. So be comfortable with the types and where to find them. So other things we need to know to really picture the anatomy of the human body are ligaments. Ligaments seem to confuse people a little bit. So I really want to make it clear, and you should have a clear understanding of what a ligament is. A ligament is a band of connective tissue that connect two bones together. So here we are looking at somebody's right knee. It's their right knee. And you could see your tibia, you could see the fibula on the outside or the lateral point. And along the outside, you'll see what's called the lateral collateral ligament, okay, and the medial collateral ligament. All those are bands of fibrous tissue. What these are going to do, what a ligament is there for, is to prevent movement in undesirable planes. So on our knee joint, we do not want our knee joint to be bending outside and inside, right? So that would cause an injury. And those ligaments protect my knee joint from bending straight out to the side or straight inside. Instead, my knee joint goes forward and back, right? So that is how a ligament works. I often picture a ligament almost like a band-aid between two joints. It's just, or a strap between two joints. It does not contract. A muscle contracts. A ligament does not contract. And because of these ligaments, it limits movement. And it's supposed to. So once again, look at your knee. Imagine trying to bend your knee straight directly out to the side. You can't do that. And the reason why you cannot do that is because of the ligaments. Another example is well, first of all, I should make it very clear. There are ligaments around every single joint, multiple ligaments around every single joint. But the other example I'm going to use is your ankle joint. So when you take your ankle, if you go to roll your ankle like people do, where the inside sole of your foot comes inwards, and people sprain their ankle, that's called an inversion sprain. What they're doing is they're spraining all those ligaments that are trying to prevent that movement. So all the ligaments that are on the outside of the ankle and foot, when they roll their ankle, that's what they sprain. So ligaments are there to limit the range and extent of undesirable movements. We don't, for the most part, want to be stretching ligaments a lot. They're there to protect our joints. Having loose ligaments usually means things are unstable. Not always, but it usually means things are unstable. Okay, so these are mechanical reinforcements preventing movement in undesirable planes. We find ligaments in all different joints, and they are there to help reinforce the joint and to guide movement in other directions. So that is different from a tendon. So once again, these are a couple concepts that people tend to confuse. So the ligaments are just bands of connective tissue, like straps, that go from one bone to the other. A tendon is also fibrous tissue, similar to a ligament. However, a tendon will attach a bone to a muscle. So on here, you see the bone, and then you see where it's a little bit of white, the lighter color, and then you see the red of the muscle. That is your tendon. So tendons attach bone to muscle. Tendons also are unable to shorten and contract. It's the muscles that shorten and contract, and in turn, they pull on a tendon, and the tendon will pull on the bone. So a muscle will shorten, it will pull on a tendon, the tendon will pull on the bone, and movement will occur at a joint. The ligaments would be reinforcing either side of that joint to make sure that the muscles can only pull the bone in the desirable plane of motion. So tough fibrous connective tissue that attaches muscles to bone. Muscles pull on tendons, which pull on the bone to move the bone. They provide mechanical leverage and strength that the muscle needs to move the bone in the desired action. So I've already mentioned anatomical position just a little bit because we needed to know it in order to understand the radius, which is on the same side as the thumb, and the ulna in the forearm. But this lady is standing in what we call anatomical position. So we're about to talk about different ways of describing movement and placement on the body. And to know what this is, we have to understand anatomical position. So this is our standard reference position used to describe anatomy. Okay, and surgeons, doctors, dentists, any kind of person that works with the human body, you understands anatomical position and will use reference words, which we're about to see, to describe things. So anatomical position, the body is standing upright with the feet slightly apart, arms are by the sides, the head points forward, and the most important part is that the palm faces forward, exactly like she has. Once you picture that, these other movements we're about to discuss will make more sense. All right, now we're going to talk about different body positions and how to describe positions in the body, where things are found, and give us an idea of how movement will occur. Our body positions are relative to anatomical positions. So once again, feet forward, head forward, standing upright, palms forward. So if I say something is anterior, that means that it is situated in the front of or towards the front. So these positions are all relative. So something is anterior, it is anterior to something else. So here is the example. Our shins are anterior to our calves. Another way of thinking it is our eyes are anterior to our ears. Okay, more in front of, anterior. The next one is posterior. So this will be situated behind or towards the back. And the example here are the erector spinae. The group is at posterior to the abdominals. So the muscles in the low back are posterior to the abdominals. You can look at it too that your heel is posterior to your toes on your foot. Your heel is posterior, situated towards the back. The midline is an imaginary line which trends down the middle of the body and will divide our body into equal right and left halves. So knowing where our midline is, this imaginary line through our body, we will use two terms, and these two terms tend to confuse people a little bit. So please be very familiar with these ones. These ones are probably the two that confuse the most, and that is medial and lateral. So medial, if I say something is medial, that means that it is towards the midline, or the body movement is towards the midline. So let's take a second and think about our shins. When you looked at that picture, the tibia, the main shin bone, is medial more towards the midline than the fibula. The fibula, in turn, is away from the midline, so it's more lateral. Okay? So let's take our hand in anatomical position. So remember, your palm will face forward if you're in anatomical position. And you can say your pinky finger is medial to your thumb, and your thumb is lateral to your pinky finger. Let's look at our forearm in anatomical position. Your ulna is medial to your radius. Your radius is lateral to your ulna. You could also look at it with your shoulders. So my sternum, my breastbone in the front, is medial to my shoulder. Or I could say my shoulder is lateral to my sternum. My nose is medial to my eyes. My eyes are lateral to my nose. And you'll find in a moment, when we start to talk about movements that occur in the body, if we move away from the midline, so if I stand with my arm by my side and I lift my arm up and away out to the side, I would refer to that as a lateral movement. Whereas if I have my arm out to the side and I'm bringing it down towards my body, I'd refer to that as a medial movement. If you look back to see that picture we had of the knee and the ligaments of the knee, you'll see how we use this term with the body. That the middle, when you saw the knee, you had a medial collateral ligament. That was the collateral ligament on the inside of the knee, the medial aspect. And we also had a lateral collateral ligament, which was a ligament on the outside. So as you review, when you get through that, to that point, you'll notice that the medial and lateral. So very important concepts to understand. Other ones that'll matter are plantar. The plantar surface of our foot is the bottom of our foot, so the sole of our foot, what we walk on. And I like to think of this as plants. We walk on plants, plantar. The top of the foot, so the back part of the foot that points upward, that is your dorsum of your foot. Plantar is the bottom of the foot. Dorsum is the back of the foot. The other terms that we'll use are supine and prone. Supine means that the body is horizontal with the face up. Prone would be the body horizontal, face down. So if you are lying prone, you would be lying on your stomach. If you are lying supine, you would be laying on your back. We use prone and supine to also determine hand positions. So if you bend at your elbow now, so please bend your elbow and sit with your hand up, your palm up, like you're going to hold something. that would be, your palm would be supine. Okay, palm up is supine, which also would match your body position and anatomical position. So if you remained with your arms by your side in anatomical position and laid on your back, you'd be supine. Okay, the way I remember it is that your palm up, you'd be holding a bowl of soup. Supine, palm upwards, versus prone means palm downwards. Once again, if you maintained your arms in anatomical position and just moved your body, that would have you stomach down. Stomach down would be palms down, which would be prone. Now, the next concept, which does cause some confusion, but we'll take it nice and slowly, are the planes of the body. So the first picture, you have the gentleman standing in anatomical position. So you see the palm of his hands forward. If I was to run a plane through the middle of your body, okay, so look at that first one. It says the mid-sagittal plane. I'm going to change it to just sagittal plane, the sagittal plane. Picture that plane going through his body like being a sheet of glass. All he would be able to do for movements, if he doesn't want to run into that sheet of glass, he has to move along that sheet of glass. So that would be movement in the sagittal plane. So if he was to walk straight forward, can you see that he would be moving along the plane? So walking would be considered moving in your sagittal plane. Sagittal plane. Okay. So you'll see in a moment that movements such as flexion and extension occur in the sagittal plane. Allows front and back movement. Picture it like a sheet of glass and he has to move along that plane. The next plane of the body is your frontal plane. So this will cut the body into front and back halves. The frontal plane will allow for lateral movement, movement to the sides. So now, once again, if you picture this as a sheet of glass, he would have to break through that sheet of glass to do a walking motion. But if he did a movement like a jumping jack straight out to the side, that would be movements in the frontal plane. And we'll see in just a moment that that is going to be horizontal, or not, sorry, pardon me, not horizontal. It would be abduction and adduction. So think jumping jacks for the frontal plane. That's a movement along the frontal plane. The final plane that we'll deal with is a transverse plane. This plane will cut the body into upper and lower halves, and this is the plane upon which rotational movements occur. Rotational. So if you were to rotate your head over to look behind you, you'd be working in your transverse plane. As we go through the different body movements in just a moment, have this page handy because I will be referring back to the sagittal plane, the frontal plane, and transverse plane, so you could line things up onto what they'd be. So for the most part, when you picture these, you move along a plane. You move along a plane so that I always picture it like a sheet of glass. So sagittal plane would be walking, frontal plane would be jumping jacks, transverse plane would be rotation. So here are the movements now. So the joint actions. Flexion, this is when adjacent bones move together, decreasing the angle between them. This is a movement that occurs along the sagittal plane. So remember I said walking, that's movements of flexion and extension. Exactly what that is. And we're going to see a lot of examples in just a moment. Extension is that the adjacent bones move apart and increase the angle between them. This is often also how we return the body part to anatomical position from a flexed position. And the example is straightening the elbows. So let's look at a visual of these. It'll be easier to see something. Okay? So having her bend her elbows, so look at the second picture of elbow flexion. Her bending the elbows up so her hands moving towards her shoulder. That is elbow flexion. Having her straighten her arm back down so her hand goes by her sides, that is elbow extension. Elbow flexion, the hand moves towards the shoulder. Elbow extension, the hand will move back down towards the hips. Now, shoulder flexion works in the same way. So if you stand with your arms by your side and then you take your arms out in front of you almost like zombie walk, that is going to be shoulder flexion. And then when you return the arm back down to your side, you'll be going through shoulder extension. The hip will work the same way. If you were to take your leg, stand up and take your leg, and do almost like you're doing a soccer kick, straight forward, lift that whole leg straight forward at your hip joint, that is hip flexion, and then returning the leg back down will be hip extension. The one that's a little confusing, the one that does not follow the rules of the other three, will be knee flexion and extension. So if I stand up and I bend at the knee to take my heel towards my glute, so I bring my heel up into the air, that is knee flexion. When I straighten my knee to allow my foot to go back down to the ground, that is knee extension. My advice to you, always picture the elbow. If you know what elbow flexion and elbow extension looks like, they work the same at the hip and the shoulder. So the knee, hip, and shoulder all look the same, and the easiest one that you can't make mistakes with is the elbow, so use that as a reference, and simply know that the knee is in the opposite direction. So here we have shoulder flexion. So she's bringing her arms up like a zombie. She's flexing her shoulders. Notice that goes in the same direction as her elbow flexion went. And then on the second picture, she is straightening the arm or turning the hands back to her sides, and that is shoulder extension. Now, in this diagram, we're talking about what's happening at the knee. However, I'll point out that this gentleman is standing with his left hip flexed and his right hip extended. So even though we're going to talk about in a second the movements of the knee, in the first diagram his hip is flexed, and in the second in both diagrams I should say, his left hip is flexed and his right hip is extended. Remember I said the knee goes in the opposite direction? So knee extension is having the knee straight. Knee flexion is having the knee bent. Similar to what I've mentioned with anatomy, you're going to have to review all of these. Go over it a bunch of times. Use your study guide. Use this video. Use your textbook. Review it. Review it, review it, review it, and it will become second nature. Right now, if you've never looked at this before, it can be a little overwhelming. So I put this positions of the neck next just so that you could see neck and spinal flexion and extension. So I can flex, and these are all happening in that sagittal plane. I could flex my neck, my cervical spine, forward. I flex it forward by dropping my chin to the chest. I extend my cervical spine by returning it back to neutral position. I could flex my thoracic and lumbar spine by bending forward. I extend it by returning to normal. Okay, so flexion and extension occur in the sagittal plane. The next we have is abduction and adduction. They sound confusing, but it's an abduction versus an adduction. Abduction or adduction. So abduction and adduction can only happen in our limbs. Okay, our torso and our spine will laterally flex. It doesn't abduct and adduct. So only think about movement at the shoulder. You can get a little bit at the wrist as well and ankle. Okay, but mainly think shoulder and hip. So on abduction, your arms or your legs will move laterally away from the midline of the body. So if you're picturing a jumping jack, picture as you jump outwards into the star position. That is abduction. You'd be doing it with your shoulder and your hip. Abduction. You moved away from the midline of the body. This is happening in the frontal plane. Adduction, adduction, is the body segment moving back towards the midline, or a limb is being added to the body. Okay, so in abduction, abduction, it was abducted away. Adduction, adduction, you're adding it back in. So it also occurs in the frontal plane. And the way I want you to picture this on your jumping jack is as you jump your arms and legs back together. That is adduction. So once again, a jumping jack, you jump out into the start position, you abducted, you abducted your shoulder and your hip joint. You moved away from the midline. And then when you jump your arms and legs back together, you adducted, you adducted. And now on here, ignore a few of these pictures here. Ignore the hip extension, hip flexion. Instead, I want you to look down to the bottom right corner. She is showing the hip in abduction. She would be taking that leg away from the supporting leg. And on adduction, adduction, she's moving it back together. And this happens in the frontal plane. The other one is simply showing extension and flexion of the hip. So muscle review this. In that first one, the lady's right leg is extending back. Whereas in the bottom left picture, she is flexing her hip forward. Remember, the hip goes in the same direction as the elbows would with flexion and extension. So rotation. Rotation is a body part that moves along its own long axis, and it occurs in the transverse plane. So this is you turning your head back and forth. Okay, so shaking your head no. That is rotation of the head. The other places we could really do a lot of rotation is at our shoulder joint and our hip joint. So you can stand up now and take your right hip and rotate it inwards until your toe points in. That would be internal rotation, or it's also medial rotation, moving towards the midline. Or you can rotate your hip, or you could do the same thing at your shoulder joint, externally. So you're pointing the toe away from the body, and the arm would go in the same direction. That's external or lateral rotation. This is different than circumduction. Circumduction is actually just doing a big circle with something. So this is where you would circle your arm or leg to go through flexion, extension, abduction, and adduction. Okay, so rotation goes along a long axis. So just always rotation, picture shaking your head no. That is rotation. Same thing happens at the shoulder and the elbow. Shoulder and the hip. Circumduction is a big circle. So you'll see a picture here. Okay. So here we have hip rotation. So on the bottom left, you notice that she's twisting at her hip to point her toe out. That is hip external, or also called lateral rotation. And then on the picture on the right, she's using her right leg, and she's internally or medially rotating her hip. She could also do the same thing with her neck and spine. You would just call that rotation, though. You wouldn't call it internal or external with the spine. Now this gentleman is doing circumduction. So take a look at the left. He's starting in neutral position. He's flexing at the shoulder. He's flexing all the way up, and then he's going to be abducting and then adducting and returning back to normal. He's doing a big circle with his shoulder. That is circumduction, different from rotation. So remember I told you abduction and adduction only occur in the arms and legs, okay, in the appendages. If you take the head from side to side, we do not call that abduction. Instead, we have a term for it of lateral flexion. The only thing that can laterally flex is the spine. The spine laterally flexes. So this is where the head or torso is bent to the side. Okay, so if you look upright and then you take your right ear to your right shoulder, we would call that right lateral flexion. If you look straight forward and then you bent your left ear to your left shoulder, that is left lateral flexion. Hyperextension are movements that go beyond anatomical position. So technically, extension will occur up until we reach anatomical position. So you will flex something forward, and extension will continue until you reach anatomical position. Hyperextension is what occurs when you go beyond anatomical position. So if you take your chin and you drop it down to your chest, you will be flexing your neck forward, your cervical spine forward. If you return your head up so you're looking directly forward, we would say that you are extending your neck. But then if you continue to go back to look straight up towards the ceiling, now you are hyperextending the spine. Same thing with the spine. So if you were to bend forward to touch your toes, if you were to stand up and bend forward to touch your toes, you would be flexing your thoracic and lumbar spine. You extend it back to an upright position, and now if you arch backwards, you'd be hyperextending the spine. Other examples can be at that hip. So remember when you saw that picture of the individual bringing their hip forward, that would be flexing. Extending would take them back to midline. And then in that, actually the one diagram with the girl on all fours where she's taking that one leg up and back, she'd actually be hyperextending the hip. So there's flexion, there's extension. I have this on there. There you see rotation of the neck. She would be doing right rotation of the neck. And then in the far right picture, she's actually doing left lateral flexion. She's bending to her left. So the next four positions are specific to your foot and your ankle. It's dorsiflexion and plantar flexion. If you take your foot, remember I told you the top of your foot was called your dorsum? If you took your foot and straighten your leg out in front of you, now bring your foot up so your toes are pointing upwards, okay? So you're bringing the top of your foot towards your shin bone. That is dorsiflexion, dorsiflexion. The opposite direction is plantar. So if you point your foot away from you towards the plantar or bottom surface of your foot, we call this plantar flexion. So you're pointing towards the plants. For anyone that's seen a ballerina and the ballerinas are pointing their toes, they are performing plantar flexion. So again, dorsiflexion, you'd be bringing the back of the top part of your foot up towards your shin, so your toes up towards your shin. That is dorsiflexion. And then if you point your toes away from you, so you would stand up on your tiptoes in this example, that is plantar flexion. The next two at first seem confusing, but I'll show you a nice way to remember. It's inversion and eversion. This is going to be movement that is happening along the frontal plane. So on inversion, you are going to turn the soles of your feet in to face each other. That is inversion, and I remember it by simply saying I am pointing the soles of my feet in. I contrast that with eversion, which is where I would then rotate my foot so the soles of my feet point outward. Okay, so once again, inversion, soles of my feet point in. Eversion, soles of my feet point out. One way for some of you to remember, anyone that's ever sprained their ankle and they're running and they rolled their ankle, they might have been told they had an inversion sprain, where they sprained it where the sole of their foot went in. If that has occurred to you and you know the name of it, that's how you can remember what inversion is. It's the direction you had that sprain. So let's look at a picture of this. So let's start on the left. She is performing inversion. The picture on the far left. Can you see the sole of her foot points in? Inversion. On the second picture, the sole of her foot is pointing out. That is eversion. Whenever I hear inversion or eversion, I always figure out which one's inversion and eversion's the other one. Okay, so someone says, what's eversion? I'd be like, okay, inversion, sole of the foot goes in. Oh, eversion, the sole of the foot has to go out. I always think about it that way. On the third picture from the left, so I'm just reading across the screen, she is pointing her toes. She's pointing her foot down towards the plants. She's pointing her foot down towards the plantar surface of her foot. That is plantar flexion. And then on the last picture, so the picture now at the far right, she is pulling her toes up. She is pulling the top of her foot towards her shin, towards the dorsum of the foot, towards her shin. She is dorsiflexion. Once and with this one, it's easy for me to visualize plantar flexion. I always will figure out which is plantar flexion. Dorsiflexion simply is the other one. Two more movements that cause a little bit of confusion. Because of the movement that's allowed in the the shoulder joint, pardon me, the amount of movement in the shoulder joint, we are allowed and able to do horizontal abduction and horizontal adduction. So if you take your arms directly out in front of you, so like zombie arms, okay, hold the arms directly out. If you pull them apart so that they go straight out to the sides, that will be horizontal abduction. You are working in the horizontal or transverse plane. So once again, you start with your arms straight in front of you like a zombie, and then you pull them wider apart, almost like you're opening them farther to give somebody a big hug. That would be horizontal abduction. It is also called, and you should write this in your notes, horizontal extension. Horizontal abduction and horizontal extension. If my arms are already out, straight out to the side, so I've got them opened wide to give someone a hug, and I bring them back together across my chest, so I'm going from my arms straight out to the side, and I'm bringing them together into zombie arms, that is called horizontal adduction or horizontal flexion. Okay, so my arms were straight out at the sides, and I brought them together like zombie arms in front of my body. That is horizontal adduction, or also called horizontal flexion. It's worthwhile now to point out where some confusion will lie is that these body movements are movements, they're not end places. So the difference between just abducting my arms to get my arms out to the side versus doing a horizontal abduction is the path in which I moved to get there. Because if I abduct my arms out to the side, I could end up in the same position that I'd get if I did horizontal abduction. So remember, these movements will tell us how you moved to get there. Okay? The big movements that I'll use horizontal abduction are the flies. So if you're doing a reverse fly or a posterior fly, you would have some resistance and you would have the arms in front of you, either using machine or you'd be bent over in a more prone position, and you would take your arms out to the sides. Whereas horizontal adduction in isolation, that would be a chest fly, or a pec deck exercise, where your arms are out to the side with resistance, and you would pull the arms back together. The other time that we use a lot of horizontal abduction and adduction is what occurs at the push-up at the shoulder. So when I do a push-up, in the most basic visualization of a push-up, when I'm on the ground, I would say that my shoulders are horizontally abducted, and as I push up, I would be doing horizontal adduction or horizontal flexion of my shoulders. So here's a visualization. On the picture of the left, she would have her arms abducted, horizontal abduction, horizontal abduction. On the picture of the right, she would have done horizontal adduction to bring them back together. So this is moving in front of the body. So remember, it's the process in which you get there. I really, really encourage you, especially before you get into the next video that will be naming the muscles and what the muscles do. Really, really review this series very, very closely so you're really comfortable, because I will talk about a muscle causing actions at a joint, and if you're going, oh, I don't know what horizontal abduction is, it's going to confuse you. So make sure you do a lot of review before you carry on to the next video. Now the next four are movements that are unique to the scapula. So up till now, I've been talking about shoulder movements of flexion, extension, abduction, adduction, and horizontal abduction and horizontal adduction. So this is going to be how the humerus moves when it comes into contact with the scapula. There are four movements that the scapula can make upon the rib cage. So these are called the scapular movements. These four are scapular movements. So it is not my humerus moving, it's my scapula moving along my rib cage. So the first one is elevation, and this is upward movement of the shoulder, okay, of the scapula. Okay, I'm going to keep using the term scapula, I prefer that. Upward movement of the scapula. This is shrugging the shoulders. So somebody asks you a question you don't know, you would elevate, you'd shrug them up. The next movement of the scapula on the rib cage is depression. So the shoulders were up, and now you pull them back down. You depress. It's a downward movement of the scapula on the rib cage, the drooping of the shoulders. The next movement is retraction, and this is adduction of the scapula, not the humerus, the scapula. So retraction is when you squeeze your shoulder blades together in the back. So the scapula are sliding together on the rib cage. Okay, so once again, retraction, squeezing the shoulder blades together in the back. And the last one is protraction, which is technically abduction of the scapula. And this is rolling the shoulders forward. So elevation, the scapula go up. Depression, the scapula go down. Retraction, the scapula pull backwards and they adduct, so they come towards each other. In protraction, the scapula will abduct, they'll roll forward instead, and we'll see a nice visual of that. Okay, so here on the first one, he is doing a scapular retraction, so he's squeezing them together in the back. That's technically adduction, you're adding it back. Scapular depression, he's pulling his scapula down. Scapular elevation, the scapula go up towards his ear. And then scapular protraction, that's rounding the shoulders forward, and so the scapula are actually coming farther apart at the spine. So once again, when you hear these, we're talking about scapula, you notice his arm is not going up and down. That's not what's happening here. The arm does not go up and down, so the humerus does not move. When we talk about retraction, depression, elevation, protraction, we're talking about the scapula moving on the rib cage. So just a couple more. Don't worry too much about this one, but you can actually upwards rotate your scapula. So what will actually happen is that if you abduct your humerus, so if you take your arm out to the side and keep going all the way up, at a certain point, you'll actually find that your scapula, your shoulder blade, will rotate up. Okay? So scapular movement that's upward and laterally that accompanies shoulder joint abduction. So once again, to create upward rotation of the scapula, the easiest way is to actually abduct your shoulder joint, so your humerus will be moving away and up, and once it reaches a certain point, you get upward rotation of the scapula. Don't worry too much about that one. The other two that do matter are supination and pronation. Supination is when the palm would be positioned in a palm up position. So that would be holding a bowl of soup. That's why I always remember it. Supination, supination, palms up. Pronation would be a palms down position. I don't have a picture for you for scapular rotation. However, we have pronation and supination. So pronation, the palm is facing down. Supination, the palm is facing upwards. So you're supinated. This is actually also true with the feet. It's just not as clear with the feet as it is with the hands. So you hear about people that are pronated in their feet. That means their feet are flatter, versus a supinated individual in their feet would mean that their arches are higher. So just a little bit of review. So here you have spinal hyperextension. So remember when I said hyperextension is when you've gone beyond anatomical position. So if you actually go to the far right of that top row of pictures, you'll see spinal flexion. So she flexed forward. She would extend up to neutral spine, which is the middle picture. And then if she went beyond neutral spine, which is the far left picture, she'd be doing spinal hyperextension. Spinal lateral flexion, that's bending to the side. Spinal rotation, you see her, she's doing it as a stretch. That's in the middle picture. And then technically at the bottom, the individual doing Sphinx pose, that's technically spinal hyperextension. She's going beyond the midline.